on the topic of postpartum psychosis. So the topic is like a medical emergency. So it's having a lot of social problems and with family crisis also comes in between. So to enlighten on this topic, we have an eminent speaker from NIMHANS, Dr. Jaisoorya T S. So over to you, sir.
Good evening. Can you hear me? Can you hear me? Yes? Okay. So, we're talking about, I first thank the association for calling me. All of them are my friends for several decades. Bill sir was the person who called me multiple times, and Sunny sir and the chairpersons, two of them are very close friends of mine. So, good to be back here. And I'm talking about postpartum psychiatric disorders. It's a very vast topic. And I'll try to condense it to some practical considerations which will be useful for you both as obstetricians, PG students, or physicians. That is my target and that is my remit. I don't think I can do anything more than that in 20 minutes. This is more or less for introduction. If you take a woman, the postpartum period is the period of highest risk in the life cycle. Okay, and that is proven. So much so, you can develop a new onset of illness, which means that for the first time a woman can develop an illness, or if they have an existing illness, they can worsen during the postpartum period. Okay. Second, the prevalence is not low. When you talk about prevalence of any other illness, it might not be so high. However, it's 1 in 2 of every 10 people, or maybe 10 out of 20 of people of every 100 will have some sort of psychiatric diagnosis that they can go. I'm not saying that all of them should be treated. However, these are diagnosable psychiatric conditions. And while we talk about reducing the maternal death or maternal mortality rate to less than whatever it is and matching the world Western standards, please remember the rates of suicide amongst maternal women have not decreased, which means, like in the West, death by suicide in the first year postpartum will be the commonest reasons for maternal death going forward for the state of Kerala. Also remember that if you have a mental illness or a mental disorder which is diagnosed and untreated, the outcomes for the infant in the first year is always going to be bad. And sometimes people say that outcomes can persist maybe in the second and third decade, both in terms of cognitive issues and mental disorders. Despite all this, despite there is overwhelming evidence for this sort of bad outcomes for the mother and the child, there's a reluctance to ask, a reluctance to share. That is where we go back to what could be the etiology. This is the only slide which will have an etiology, because all other things are going to be practical, but I want you to understand why the postpartum period is the period of highest risk. Mainly, obviously, you know that within 48 to 70 days, I'm not obstetrician, so you might be right. When you say something about the hormones, you might be right, but we all know that within 2 to 7 days, all the high levels of hormones which was there in the pregnancy falls precipitously down. We also know it's a hyperinflammatory state for whatever reason normal changes to happen. And in the background of this, if you have a genetic risk, then with the sleep alterations that happen with normal pregnancy and delivery, and if you do have these factors, the psychosocial factors, which is where I'm coming from, why I put up this slide is presentation of mental illness in postpartum period is just not about biology alone. It is not only the biological factors that determine it. This particular factor where there is a history of psychiatric disorders, current life stresses, poor relationship with the partner, all these will add up to the genetic risk to create the next set of disorders. I will just go briefly through the groups. We have postpartum blues, we have postpartum depression, postpartum psychosis. I know just the association asked me to talk specifically of postpartum psychosis, but if I don't anchor that, probably you will not be able to understand the perspective that postpartum psychiatric disorders come from. Postpartum blues is normal. It happens for most women. Okay. First week of pregnancy, however prepared you are, the baby is born, you become unsure. The baby is born, whatever everyone has told you, suddenly everything changes. Suddenly you become primarily responsible for someone, especially in the primary parents women. And then you have sleep disturbance, you become very unsure, you become very insecure, you become a little bit teary, and all this is only what postpartum blues is about. It's not a psychiatric disorder. However, you should remember that with adequate support and reassurance, which means that if you are an obstetrician, if you are a physician call, or you just have to say, it's okay. You just tell the family if she is teary, don't worry about it. It's something that will settle down. You just give her some support, give her some time to sleep, give her some time to rest. That will be sorted. However, that's not the case for postpartum depression. When people move from postpartum blues and the symptoms start persisting beyond the first 2 weeks, and when they come for your postnatal follow-up, the first follow-up, and the parents or the caregiver or the patient start talking about depressive symptoms, then that is the point when you should start believing that there is something that is going on. Also remember, especially if the infant outcome has been bad, if the actual labor was bad, that means they had a lot of complication, pregnancy, etc. All these are risk factors for postpartum depression. These are the symptoms of depression. You know it, I know it, we have heard it. It's a short note for all of people, we know it. However, specifically for postpartum depression, look for things specific to the child, infant, where they say, I have a problem in taking care of the baby, when there is absolutely no problem. When they start talking about, I'm not good enough, I cannot take care of the baby, I feel very, very insecure. എനിക്ക് ചെയ്യാൻ പറ്റുന്നില്ല, എന്തോ ഇതെല്ലാം ശരിയാകുന്നില്ല, I'm not a perfect mother. Or they start saying that there is a problem with the baby. The pediatrician said there's no problem with the baby. The mother is saying, I think there's a problem with the baby. I have severe health anxiety about the baby. That is when, in the background of sleep and appetite disturbance, is the time when you start thinking of postpartum depression. Of course, I go back. As the symptoms worsen, they'll have more scary thoughts about the baby. They'll have thoughts about harming the baby. They'll have thoughts of harming self. Their sleep and appetite disturbances will worsen, and their self-care will worsen. By the time, if you get someone like that, that is a mandatory psychiatric referral. Of course, when people come early, I'll tell you what to do. But if people come late and with more severe symptoms, if concerns are raised, harm questions are put forward, please ensure that the referral is given. You have to remember the difference between postpartum blues and postpartum depression is one, it is a severity, it is a chronicity, and it is a dysfunction. Postpartum blues doesn't have dysfunction, it's just an insecure period when people have some insecurity, they just manage. Then you know you're postpartum blues. If they start saying that she is not able to take care of the child, then you're looking for postpartum depression. Suicidal is significant. We were coming on to that. Remember, suicidal is a significant risk. You have to be clear about that. It also has a significant impact on mother-infant bonding. One of the reasons why the anhedonia, when you talk about anhedonia, that's a classical symptom of where they can't experience pleasure. When the mother actually says, I don't enjoy the baby, that is anhedonia in postpartum mothers. That is what you need to say is a very sensitive sign that obstetricians can pick. There's an issue with lactation, breastfeeding, which we'll come to later. There is also need, when you don't have attachment to the baby, you don't emotionally play with the baby, then the cognitive and emotional development is affected. The assessment is very, very clear. One, As an obstetrician, you don't have time. You're seeing 30 patients, 40 patients, 60 patients, 80 patients, 100 patients. Two questions. Is she able to manage herself? Is she able to manage this time? The answer to the two questions will give you the severity of the depression. Okay. Second, ask the family whether they are expressing thoughts of harming the child. എനിക്ക് മരിക്കണം, എനിക്ക് ജീവിക്കണ്ട, അങ്ങനെയുള്ള ചോദ്യങ്ങളും അങ്ങനെയുള്ള കോൺവെർസേഷൻ ഞാനും കൊച്ചും ഞാൻ പോയാണ് എന്നുള്ള കോൺവെർസേഷൻസ് ഒക്കെ വന്നു കഴിഞ്ഞാൽ ഇറ്റ്സ് സംതിങ് വെരി വെരി സീരിയസ് ആൻഡ് യു ഷുഡ് നോട്ട് കീപ് ഇറ്റ് ഓൺ. There are not many investigations, but always do a full thyroid profile. You have to do that whole thing. Because what we know is that most consistent relationship with postpartum depression is with thyroid abnormalities. Vitamin D is said, anemia anyway you will do in the postpartum. But thyroid, a full profile. You have to correct it, correct the TSH to less than 3. It's an aggressive correction that you need to make. Okay, that has to be done without fail. Mild again, nothing, no problem. She's saying that you just tell the family that please take care. Tell the partner please take care. You give some more support, ensure that she sleeps, that is settle down. Moderate, that is when you have counseling facility is not available. Someone who is a good counselor, they can go for counseling, but then medication is the first choice always. Severe, of course, that changes completely. There's no question of any counseling. And if you are very suicidal, then ECT is the modality of choice. Same thing which you would do all across. Okay. Or you would not do polypharmacy, you would do single dose. And of course, if they're breastfeeding, then you need to take an appropriate medication which will fit to the breastfeeding group. Again, don't give long-acting medication. Always give short-acting medications, which if you're giving long-acting medication, then the relative infant dose should be less than 5%, not anything more than that. Okay, be careful about that. What would you give? This is what you would give as first line. Don't have any doubts about it. Sertraline, drug of choice. No doubts about it. Okay, that is the drug that you have to give. That has the best evidence. It is lactation friendly. You can breastfeed when you're on a sertraline, 50 mg. Patient is improving 100 mg once daily. Then the issue is whether most people with depression don't sleep. Okay, what do? You give some medication with sedation, or some of the older drugs. When all of us were students, then we used to use prothadine, dosulfin, dothipin. It was some of the senior physicians will be very familiar with the drug. Easy drug to give, once daily, 25 mg. You can build it up to 75. The patient does not respond with 75. I don't think you should hold on. You should refer them on. Okay. Similarly, imipramine, amitriptyline. Of course, remember that imipramine, amitriptyline has more sedation, more constipation, all these issues are there. So maybe you should not use all those drugs. But then mirtazapine, which is the newer drug which is common, is also very useful for people who have sleep problems. Benzodiazepines is generally discouraged except the low short-acting, because you have a long-acting benzodiazepine, it goes into breast milk, the infant will be floppy, will not feed, it will not engage, and that's something that you need to avoid. How long to treat? That's the most important thing you should remember. If you have a postpartum depression, someone who has been depressed for a month, who has been seeing you after 2 months, and then they say depression is light from there, do not stop medication early. Do not stop after 1 month because the patient has improved. At least a 6-month period, after the patient has responded to treatment. That is the most important thing. 6 months after the patient has become well. Clear? This, as I said, it's not all about medications alone. It's about support. It's about support of the partner. It's about ensure some rest, ensure that patient, and that is always about psychological mental health issues. Need that help during the period during which they are symptomatic. When to refer? When the severity is there, worsening symptoms despite treatment, risk of harm to self and others. That is something that you are aware of. Okay. Then we come to the core topic that we have been talking about. I will not spend much time on this, but then I want to talk about it because it's the most severe form of mental illness in the postpartum period. Not uncommon. I'm not saying it's common. because we have 1 to 2 per 1,000 births. Higher in primary parents. Highest risk when you already have a psychiatric illness, which means that in the postpartum period, as I said, they can worsen, which means they can relapse. And the most important thing is they have its onset abruptly, which means that you go as an obstetrician to do an obstetric follow-up, which you normally do after cesarean section, 3 days, 5 days you will have emerging symptoms in that particular period itself. Or you have a very quick onset, the patient will be perfectly well. On the first day you go, next day you come, back. And they go into from 100 to 0 in just 24 to 48 hours. That is the issue where people always end up saying, is there something organic? Now, before I go into why the organicity, you should remember that the symptoms are in a phase, which means symptoms are very obvious. There is nothing subtle about postpartum psychosis. The mood swings are definite. The people will say, ഒരു മണിക്കൂർ മുമ്പ് അവൾക്ക് പ്രശ്നം ഉണ്ടായില്ല, ഇപ്പൊ കണ്ട കരഞ്ഞോണ്ടിരിക്കുന്നത്. കുറെ കഴിയുമ്പോൾ ദേഷ്യം. Then she will not be sitting around, she will just be wandering around. Okay. And then if she talks about, she'll talk bizarrely about things. I think my baby is a devil. I think the devil is possessing me. I hear sounds of some people coming and talking to me. Okay, someone is there, someone is standing there. So forming auditory and visual hallucination, not sleeping and not eating at all. And of course, self-care is a given and taken. It's gone. So there is no way that you cannot see postpartum psychosis, because as I said, the most surprising thing is it happens, you leave the patient, you leave him there, go back, come next day, it's done. You see that on your face. So anyone who has seen postpartum psychosis will not forget the postpartum psychosis, because it's very clear. And remember, all the psychopathology will have a child thing, which means if they're delusion, they will say, my child is disfigured. It's hallucinations, the voice saying that my child is actually the devil. He's evil. So those things are something that you will hear as you go. Suicide risk is very, very high. That's what I'm saying. It's about you identifying and ensuring specialist support. So do not hold on to and saying that it's okay, we'll see. The family might say, doctor, don't really fall for that. Postpartum depression, you can do that. Postpartum psychosis, never. Okay. There is also a risk that you go away, the mother might simply throw away the baby. So it's not just about the mother, it's about the child or the infant. And neglect, they will not bother about the child. The least, they will not take care of the baby. That is something which is certain. That is where the issue is, whether it is organic. Okay. It could be organic. I'm not saying it cannot be, because when you have a rapid deterioration, a complete change of picture from normalcy to abnormality, then the first thing in a postpartum period is, is it organic? It could be. If you have a very severe confusion, because confusion is also there in postpartum psychosis, but the confusion is simply, if they simply cannot recognize the mother, their own mother they can't recognize, they cannot recognize a partner, then you are looking at something different. If they, in postpartum psychosis, they actually recognize people. That might fluctuate a bit, but they keep recognizing. But if they simply are completely disoriented, then you're looking at that. And then, oh, it's over. Okay. I'll take one more moment. And then you have fever. Fever is there, severe headache. Then there is signs of focal neurologic deficit. That is when you really talk about it. If you do it, if you are looking at what it is, there are possibilities here. Cerebrovascular high end, you need to look for thrombosis also, in addition to stroke and all this focal neurologic deficit. You need to look for all these hyponatremia, hyponatremia, hypoglycemia, etc. Failures, all these. Medications is one thing. Infections if you have fever. And then drug use. Remember, we are shifting to a generation where you will actually feel that people will not use drugs, but always be a little bit suspicious, because we are getting early trends. I work in Bangalore, so we are getting early trends where the urine urine is showing positive for illicit drug use. So you should be careful about that. I'm just saying it's not here at but then it'll come here. It's primarily a psychiatric illness, okay? This I'm not saying. But always ask that question, does she have a psychiatric illness? Did she have medications on psychiatric illness? Did they stop suddenly? Or did they stop because of some advice? If that is the case, then you have a clear evidence of it. Okay. But remember, that's not indicated. Because 40% of people not have any psychiatric illness. The first time they have any particular problems when they have the postpartum period. I'm not going into this. Psychosocial factors are not very important. I talked about it, support and all these are not the reason why postpartum psychosis is a biologically driven process. We talked about it in postpartum depression, that is more there. But remember, it's a psychiatric emergency, it's a medical emergency, it's an obstetric emergency. Okay, that requires hospitalization. Don't discharge the patient. Ensure psychiatric input. What do? Emergency management. I would always go for oral olanzapine 5 to 10 mg. If the psychiatrist is not there, just give out the olanzapine 5 to 10 mg. Not manageable, give injection haloperidol 2.5 or 5 plus promethazine 25. You can do with that. You can have these two drugs in mind. Do not bother about it. Psychiatrist will come in 3 hours. You have nothing to do. Just give out the olanzapine 10 mg. And if it is not controlling, just give it a injection to just care of the infant is important because mothers should not be left, postpartum psychosis should not be left to the child. They should be taken away or they should be strictly supervised. If not, you are in trouble. Okay. Initial step, this is what I talked about. If you want sedation, lorazepam 1 to 2 mg can be used. Chlorpromazine also with the older antipsychotic can be used. These are all things for a psychiatrist. Prognosis, though it is very, very on your face, is actually very good. Okay. The only issue is the next time the pregnancy happens, you should be aware if there is a process of postpartum psychosis, next time it will be very likely to come. Okay. This breastfeeding you should know. You should prescribe drugs which low infant levels, encourage breastfeeding. There is always this issue where we actually say, there is no basis of that because basically once steady state is reached, the blood levels are the same. It doesn't matter, but we all say that they are also happy, we are also happy. Okay. This, again, I'm not going to some more details. Once a first person has postpartum psychosis recovered, please ensure that they have at least one session with a counselor to talk about their experience. It's a very frightening experience. We were talking about it. Frightening experience for family, frightening experience for individual, frightening experience for the couple. Just let them talk to them and talk about their experience and somewhere understand. Otherwise, it's very difficult, especially when you never had an illness ever and suddenly it comes from nowhere. So ensure that something is understood in that way. Okay. The last thing that I want to say, which is a very important thing that you have to know is, starting medication, starting treatment, psychiatric treatment, the postpartum period is about the advantage and disadvantage of one. I'm just not talking with postpartum, it's also with pregnancy, is about the benefits and risks of starting medication, treating an illness, etc., etc., etc. Please document it. If you do not document it, you have a problem because we now see in demands where people are treated maybe in Kerala, maybe in Karnataka, maybe in Andhra Pradesh, etc., who come for a second opinion. The people who come for a second opinion are not the people who took them. I'm a parent, okay? I'm a parent. You take them for postpartum psychosis. The parent takes a decision to, the mother says, father says, please treat them. You treat them. 3 years later, they will turn around and say, the patient will turn around and say, I didn't have anything. You took me for treatment. The doctor and you had a conspiracy, took them for treatment. I'm going to Nimmans. I'm saying not in Nimmans, but wherever they'll take and try to go against you, the people. So you will be dragged into a family conflict. You will be dragged into anything. Of course, you should treat them. Of course, whatever mandatory things you have to do. However, do not forget to document it because the issues will come where you never know. This is more what I wanted to say. Thank you very much. Sorry, I just took a few minutes more. I should have finished.
Thank you, sir, for the excellent proposition of the topic covering the entire spectrum of the postpartum mental illness, like postpartum blues, postpartum depression, and postpartum psychosis, and the treatment risk-benefit ratio in treatment and documentation. Thank you, sir. Questions?
How long does it take for the psychosis to settle, and for how long do we need to continue the medications?
That actually, madam, that's a very pertinent question. But generally, if the postpartum psychosis is the first time the person had a psychiatric illness, if you treat for 6 to 9 months is sufficient. Okay. But the person had a previous psychiatric illness and the postpartum psychosis is the relapse of the previous condition, then the whole picture changes. Again, if the symptoms are very, very severe, where she was homicidal and suicidal and you have to give ECTs, then probably you are looking for 1 to 2 years. However, postpartum psychosis is actually a good prognostic illness and has a good chance of full remission. The only thing is, she goes into the next pregnancy, the chances of relapse is high.
Sir, is there any clue that this patient will go for postpartum psychosis in the pregnancy period itself?
Yes, there are. If for example, the most common reason why people develop postpartum psychosis is not the new onset of postpartum psychosis. They will be having some psychiatric illness. The first time they develop, they become pregnant, the wife will stop or the patient will stop. Even if the parents want to stop, the patient will stop. Okay. And then it reaches the postpartum period in the highest risk and it blow up on the face. Sometimes the family also will not know the patient has not stopped. Okay. However, there are indications. Probably if you look at the other group also, there is some in the final trimester, some difficulty in sleeping. They're non-specific symptoms. You're not going to get these delusions, hallucinations, etc. But non-specific symptoms, a difficult labor, a difficult final trimester with a lot of eclampsia, pre-eclampsia, and all that coming. All these heighten the risk. But if you ask me, is there a specific thing? There is no specific.
So is olanzapine breastfeeding?
Is fine. Olanzapine is fine in breastfeeding. Sertraline is fine in breastfeeding. And all the old prothioline and all that is fine in breastfeeding. So that's why I put up those drugs.
Which patient having suicide tendency more, the postpartum depression or postpartum psychosis?
Postpartum psychosis, sir. Postpartum psychosis, it's more dangerous also. It's definitely more dangerous the more this one. That's where we always say, be safe. Safety is the priority. Safety of the mother and safety of the infant is priority. Don't leave, if the person has postpartum psychosis, don't leave the infant in the care of the mother at all. No, that's a big no. That's the first thing that you should actually do.
So in our setup, we do during antenatal period itself, we patients with some sort of anxiety and high-risk patients, we do ask them to consult a psychiatrist in our hospital itself. That makes a lot of difference in treating these such of patients.
I think I agree with you, and I think that should be standard practice because like what you said. The most important thing is how you manage the pregnancy well. If you manage the pregnancy well in a holistic, multidisciplinary fashion, you're going to get less bad outcomes in the postpartum period. I'm not just talking about psychiatry, but also all other specialties. If you have diabetes, you have thyroid, everything is done well, then you have a better baby outside.
Which is the best drug? If it is one drug to be given to the patient, which is the first drug, like benzodiazepines or antipsychotics?
So if you talk about postpartum depression, sertraline is drug of choice. 50 to 100. Okay. Safest drug. 100% evidence. Okay. When I say 100% evidence, you know what is 100% I'm talking about. If you're talking about postpartum psychosis, olanzapine. I would still go for it because it doesn't disturb. Of course, some amount of sedation will be there, except for that, it's absolutely fine. You don't require anticholinergic, etc., because less chance for EPS also. So that's fine.
Sir, very excellent talk, no? One or two questions, Jerry. Is there something called a suicide gene? Because we see some patients without any features of depression committing suicide that runs in family.
Yes, absolutely. There is no suicide gene identified as well, but then there is a serotonin transporter gene where there is an issue with the short arm, where there are some deletions in the short arm. That has higher propensity. But as you rightly said, suicide runs in families. Psychiatric illness runs in families. So if you have a patient whose sister has already committed suicide and you're looking at it, you're looking at a major issue. Okay. And like Madam said and Sir was talking about, if you get the history of psychiatric illness, if you also get a higher risk of multiple members being affected, these are all, I'm not saying red flags, but something at least orange flag or yellow flag is there, should be there.
Is ECT safe in pregnancy? No?
ECTs, there's no contraindication for ECTs in pregnancy. You can give, we have given in the final trimester, we have given just before delivery, we have given it, no problems, no outcomes. Very effective, life-saving, should be
That
given,
matters.
where it should be given.
Yeah. One more question, Jerry. Suppose you are in the bipolar depression. What mood stabilizing drugs is safe in pregnancy?
See, lithium is the best drug. Okay. There is evidence of lithium causing Epstein's anomaly in the first trimester. However, it actually is not that bad. Okay. Even if the person is not on lithium, and then you just need to, what I should say, you need to do a more intensive monitoring for fetal abnormalities. Let's say they have fetal Epstein's anomaly. Our cardiothoracic surgeons will correct it like this. It's far better than the woman dying, or far better than a woman having psychosis later.
One more thing. One acute delirium in a pregnancy, how you tackle it?
Acute delirium is a medical condition, and I think Jacob sir will be the right person to answer that question. But
haloperidol safe? Haloperidol is safe, no?
If you're talking psychotropics during delirium, then haloperidol is safe, risperidone is also safe. If you're talking about the psychiatric management, but the delirium should be managed with more related to finding out the condition and going for the condition, primary condition. But if you want to control the agitation, you can still give 5 mg, 2.5 mg haloperidol. Haloperidol is very safe all the time. It's an older drug, and people have a little bit issue.
Plus promethazine, no?
Promethazine is also very safe.
So it was an excellent talk. We understand that just delivery problems are not over. More problems ahead. We have seen some patients with minimal intracerebral bleed presenting with abnormal behavior, cortical venous thrombosis, and of course hypothyroidism. And such situations should be ruled out, as you said.
I fully agree. What means that if you have postpartum psychosis, please rule out organicity. But after that is done, keep it as a psychiatric condition. Do not really keep going on to the organic. Just keep digging and digging where nothing is there. But you have something on the face that should be treated first. That has priority. But like what Sir said, if the symptoms have very prominent, you still have to give olanzapine, you still have to give haloperidol, you still have to give risperidone to control the behavioral problems.
I think we should congratulate the organizers once again for the excellent CME. Especially the organizing chairperson, Dr. Jaisoorya, Professor Jaisoorya. Sir, arrange super. So he has proved once again. Thank you.
Thank you very much. Thank you.
Thank you, Dr. Jaisoorya, for that insightful and thought-provoking session on postpartum psychosis.